Hello, everyone. Welcome to Let's Talk, a new live stream show where I interview professionals for their opinion on mental health, addiction, and current events. My name is Dr. Aaron Weiner. I'm a licensed psychologist. I'm an addiction specialist. I'm the host of the show. I'm just very passionate about trying to connect people to the information that they need to improve on themselves, personally, professionally, as it pertains to mental health, and particularly as it pertains to addiction. So I'm really excited about my guest for today. She's a longtime friend, Dr. Kathleen Burke. She's the director of substance use initiatives in Will County, Illinois, manages the Illinois Drug Overdose Prevention Project in Will County, and sits on the Illinois Opioid Crisis Response Advisory Council. Everybody in the western and southwestern suburbs who's plugged into drug prevention knows Kathleen. She is just all over the place doing tremendous work, and I'm really excited to get her opinion today about what's going on with addiction across a number of different areas. So with that, Kathleen, welcome to the show. So glad you're here.
Thank you, Aaron. I'm very, very happy to be here. Thanks for inviting me.
Of course, of course. Well, before we dive into questions, and I should mention for those watching, please feel free to ask your own questions. If you have something that comes up, it's not every day that we get to pepper Dr. Burke with our questions. I know I have a few. So if something comes up, make sure to type it into comments and we'll work it into the broadcast. But Kathleen, could you just tell us a little bit about what you're up to right now, what your initiatives are, what you're working on?
I'd be happy to. Well, as all of us are feeling the impact of COVID-19, it has influenced the increasing overdose in our community. There's been a 30% uptick. And so our strategy for managing that is to get naloxone into the hands of as many people as possible. So we started a rapid response team, which goes into the community. These are people with lived experience who are identifying for us the hotspots, locations where we know people are using substances, and we're putting a pop-up where we have naloxone available to everybody. We coordinated with the food banks. As we all know, there's been a huge demand for food at this time, and so we're able to pass out naloxone at that time. We're attempting to help people get into treatment if they so choose, because it's been a challenge. So our response is to put that warm hand out there and to help as many people as possible. We're also in the process of training recovery coaches. We have a program with Governor State University and the workforce of Will County. We train people to be recovery coaches, and we have them in all of our treatment agencies in Will County with the anticipation that they will obtain jobs permanently in these positions. And a recovery coach is the advocate for people who are in recovery. And so as we see more and more people relapse right now, or unfortunately, or overdose, these folks can be extremely valuable to help someone get back into recovery, to get them back on the same path they were on, and to not let them derail them for a long period of time. So I'm excited about that. I'm excited that we're doing that work.
Yeah, the recovery coach angle, I know, is something that's really been pushed out by grants, and it's a great model that you actually have someone with a lived experience and an addiction-related lived experience in places where someone might otherwise fall between the cracks or get stuck. I know that emergency rooms are one place where we were really trying to get recovery coaches in. Are there other environments where you're trying to get recovery coaches in particular?
We have recovery coaches in our agencies, actual treatment agencies, outpatient agencies, cornerstone housing, places where people are have a mental health and a substance use disorder, and they do outpatient treatment. Our health center, we have a federally qualified health center. We have 2 people located there, and they work with the M8, the Medication Assisted Treatment Program. So they're following people, they're keeping in touch with people, they're helping them get to their appointments, and recovery homes. The recovery homes, we have people stationed in the recovery homes, which is really critical, because there is no support for recovery homes. The person has, out of the goodness of their heart, opens them and is trying to help people stay in recovery. We come in and help people get their lives back. you get derailed when you have a substance use disorder. So our recovery coaches help them, first of all, a lot of times get their identification back, their license, they get a job, they get housing, future housing, they maybe they have challenges with their family and they help them navigate that. They might have issues with DCFS where they have to navigate with their children. It's an opportunity to keep people moving in recovery because this COVID, this has been very challenging for people, so it keeps them linked to somebody.
Yeah, well, and I know the relapse or the recidivism rate, if you will, I mean, of substance use disorders is so much higher than a lot of other chronic medical conditions that providing that support is critical, and particularly now. And I want to make sure that we start in the issue that's always on everybody's minds, which is COVID-19, and that it obviously has been tremendously it's been incredibly detrimental to the efforts in public health that you and I have been working on for so long in terms of overdose prevention. Right prior to the pandemic, the data that the CDC released about that period actually showed that overdoses nationally actually were still on the rise. They'd gone down for a little bit there in 2018. They started going up in 2019, even before the pandemic hit. And then with the pandemic, I remember seeing this really alarming article in the Washington Post saying that like in April, I think it was March, April, and May, that the opioid overdose rate was escalating. It was like 12%, 20%, 42% in some places. How are you seeing right now the pandemic having influenced the opioid epidemic and overdose rates? And then what in public health are you guys trying to do right now to wrap your arms around it?
Well, I think there were two reasons for that, both the pandemic as well as fentanyl. So we were starting to see that rise because fentanyl, which is the substitute for heroin on the street, most of the drug is fentanyl right now. And fentanyl is very strong and it's deadly. People don't know that they're using it. We saw fentanyl mixed in with cocaine. We saw fentanyl mixed in with just about everything. So you're always seeing an increase in deaths because of the opioid that's out there. The second part with COVID, unfortunately, from a public health perspective, we responded to COVID in a way that would help people stay safe from the virus. But that safety and that response it impacted people with a substance use disorder in a very negative way. So what happened was people, their treatment facilities closed because they had to close down and set up a manner in which people would be safe if they were in there. When they opened back up, they were at a smaller capacity. So there was less opportunity for people to get treatment. Outpatient programs stopped. And then when they reopened, they opened with a virtual interaction. Virtual communication is fine, but it doesn't replace one-on-one interaction with an individual, especially when you're in early recovery. You need to know, you need to look at a person, you need to feel that connection. Support groups, the support groups stopped because you couldn't gather, right? We all had to stay home and we had to be isolated. When the support group stopped, that was devastating for people, just because that's part of everybody's routine. And when you change a routine and you break people's daily living into a lonely, isolated environment, it's not positive for them. So when telehealth came around and it was helping people reach their providers, we still lost a lot of people in there who were either they weren't able to use telehealth because they didn't have the communication tools, they didn't know how to use it, or by that time they had relapsed. And so what we're trying to do is, well, one, let the public health departments know and the community know that the COVID-19 responses are having a negative effect on substance use. And so let's fix that, right? Let's not continue that. Let's fix that. So one of the things that just happened is they changed the law for a doctor who gives Suboxone or MAT has to be specially certified. That reduces the number of available doctors able to do that. They stopped that. So they loosened the rule up, and now other physicians and nurse practitioners can provide naloxone. And a lot of what we knew, not naloxone, but Suboxone, we knew that many physicians didn't do it because it was just a hassle, right? It was just one more thing they had to do. So that's the positive side, and we hope that stays. Telehealth is great, and we hope that stays. But we also need to get back to one-on-one therapy, as well as treatment facilities being able to admit a person quickly. You had to get a COVID test. COVID slowed everybody down. If you're familiar with, with opioid overdoses in an emergency room, the ideal is to get someone into treatment or detox right away. I mean, right away. Our systems don't work that way, and COVID exacerbated that problem. So we're still talking about the fact that you cannot just treat a person for their symptoms. We need to move them into a safe environment where we can help them manage their recovery. The emergency rooms shut down. Our warm handoff people, our recovery coaches could not be in there. Nobody could be in there, right? So people died. People in people's families died. That's heartbreaking to people, but it's even more challenging to someone who has a mental health disorder or substance use disorder. And the people who know people with lived experience are losing their friends and colleagues left and right. That is traumatizing. I just read a report that from the CDC that says most challenges, trauma events, right? Like are a one-day event, right? I mean, Katrina was longer, right? But it ended, and it ended within a period of time that people could manage. Tornadoes, other fires, all of them end in a period of time. Well, COVID's been going on for a long time with no end in sight. That extreme stress over having to live like that for a long period of time is what's taking its toll on everybody, not just people with substance use disorder, but everybody.
Right. Absolutely. It's been a tremendous burden, and there are some of these structural changes around like what sort of treatment you can receive and peer support you can receive. And telehealth, I know we were planning on talking about that in a little bit, and so we'll swing back around, but it really is one of these things that is fantastic in terms of access, fantastic in terms of safety, and one-on-one, speaking as a practicing psychologist myself, I found it's been very useful and people can make progress, but it's also very different in groups when there's kind of like a natural flow and dynamic that comes from being all in one place. And it's different, and sometimes people are a bit more inhibited. If you're one of like 10 faces, and I mean, even with two people at best, you have those moments where like you start talking and they start talking, and then it's kind of awkward and it's like, no, you go. And it's tough. It's tough in those moments. So we do have a question from a listener, Mariana, who actually also reached out with another question earlier. So Mariana, please feel free to submit that now as well. But she's wondering about increases in amphetamine use. We've been talking a bit about opioids, but what about amphetamines? And I know as well that I'll piggyback on this question a little bit as well and say that I know that actually all sorts of self-medication seem to have gone up during COVID. We've seen increases in alcohol purchasing, marijuana purchasing, pornography viewing, just about everything. From a public health perspective in Will County, is there an initiative at any of these other substances, amphetamines, alcohol, et cetera? And if so, right now, what's going on?
Well, I'm happy to say that our health department is reopening their substance use therapy department. It closed many years ago, and we received a fund. We were able to fund it, and it's in the process of reopening. So that's the long-term positive thing that's coming, where people are treating all substance use and all mental health disorders. We do know that alcohol is increasing for everybody, and so the communication, though, from public health is about COVID. It's about vaccinations right now. And what we try and do with our pop-ups that go around is add as much information as possible. So we pass out masks, we pass out hotlines, we pass out information about how to take care of yourself, breast relief during this time. So we know that alcohol, they're seeing it in the ERs too. You can have someone who may have a drinking problem for a little while, and it's turning into alcohol use disorder because they're home, they're isolated, and it's increasing. So we're going to need to take care of that. We have seen in Will County, methamphetamine is here. And unfortunately, it's usually downstate. We wanted to keep it downstate, and that's not what's happening. And so that's really terrifying because we don't have the treatment that we develop for opioids, right? We have a medical assisted treatment that helps. Methamphetamine is more challenging, but I do believe there is a medication that they're testing right now for people who have a meth addiction. So that's very positive. But we can't do any kind of education in the schools because the schools aren't functioning. But we do virtual, I do virtual education all the time. So it's not to diminish the other substances. And we have seen cocaine like jumping very high. So the message is, don't die before we can get you help, right? I mean, that's why the naloxone's out there is like, we want people to stay alive. So it's harm reduction strategies that we're using. Don't use alone, don't isolate, and reach out if there's a problem. But it's a challenge all the way across the board.
I have kind of an outside the box question, when we're talking about the tools that we have available, when I think about, we do have some medication assisted therapies for alcohol, of course, that's out there. What I wonder is, what would it take to have some of these medications, like even on the alcohol side, like Antabuse, the medication that impacts the stomach enzyme so that you vomit violently if you use it, or naltrexone, what makes it's a craving reducer and makes you experience less euphoria when you drink, for listeners who aren't as aware. I wonder what it would take to maybe make those either like have a standing order like we have for naloxone or be OTC drugs. Because for both of them, interactions are actually very low. There's some liver toxicity issues that if you have liver issues, but I just kind of wonder if there's a place for that. Because imagine if people, because there's all these barriers, I feel like, to people getting help, to using medication-assisted therapy. We just removed one in terms of the X waiver, like you were saying, for physicians. For those who aren't aware, they just changed it so that physicians now can prescribe buprenorphine, which is a medication-assisted therapy drug that we have, to up to 30 patients without getting what's called their X waiver, which is what allows them and allowed them in the past to prescribe buprenorphine. So, I mean, what do you think? Should it be easier to access these products without passing through a medical gatekeeper? Or, I mean, what's your take on that?
Well, the products are dangerous, okay, medically. I don't know that I would want the average person going into the pharmacy and purchasing Antabuse or purchasing naltrexone. You do need to be under a doctor's care. And so at our health center, we do provide that. And it actually, we've seen an uptick in people using naltrexone for alcohol use disorder, even because before nobody talked about it, right? It wasn't, but now it is actively being prescribed. So that's the good news, is you're seeing those medications are helping a lot of people, not just opioids. But tell me what you're thinking about having it more accessible.
Well, I'm just thinking, so certainly there are some medications, and I should specify, I'm not a medical doctor, I'm a PhD, not an MD, coming from a psychology point of view here, but there are some medications that the risk benefit is pretty low, right? Theoretically, could you hurt yourself with a bunch of acetaminophen? Sure. Could you hurt yourself with there's a lot of things that if you used improperly could hurt you. When I think of Antabuse, for example, when I think of disulfiram, that's the generic of that, or when I think of naltrexone, which is an opioid antagonist, to me those don't seem quite as risky as some other medications that we have. And when I think about, all right, if someone wanted to try it, I'm just musing. These could be terrible ideas, but I'm just musing about it. Yeah.
Well, the first thing I'd like to see more accessible is Narcan, right? Naloxone still requires a prescription. It should be over the counter, and we're giving that out. So unfortunately, people believe it's free all the time too. So you can get it in a pharmacy. I don't know how many people feel comfortable going into the pharmacies and looking for substances like that, because even if they were over the counter, there's so much stigma attached to asking for things like that. And it's not been pleasant for people in pharmacies to approach someone for something like that. We'd like to see that change, and it has been changing slowly. But someone should be able to go to a pharmacy and ask for assistance in the same way. I have a cold, my nose, I can't breathe, I haven't, and they help you pick out the substance that will help you. You don't get that same kind of response when you go to pick up your Suboxone and are asking for other things. It's not the same. And so we have a long way to go still with people destigmatizing an addiction.
Yeah, no, definitely. And Mariana mentions here that we do have a standing order here in Illinois. Absolutely. And some other states have that as well. And actually, as long as we're on the topic of pharmacists, I'm going to follow up with her, the question she'd actually posed a couple of days ago, which was essentially how can pharmacists best contribute to the reduction and prevention of overdoses and substance use disorder, which I think is a fascinating question. I posted on LinkedIn an article that came out that was basically pointing a bit of a finger at some pharmacists with Walmart who had turned a blind eye to what was going on with the opioid epidemic. And it was just, again, just thinking about, well, so what responsibility do people have at different nodes in the pipeline? So from your experience, what do you think a pharmacist can do? Should they be taking more responsibility? What's your take?
Actually, I'd like to see pharmacists take more responsibility for educating people about the medications they might be walking away with. And because we've seen an uptick in overdoses for seniors, because sometimes senior citizens have multiple types of medications and they get confused with the labels and they get confused with what they're taking. So we're seeing, because people are isolated, pharmacists have a lot they can do to help a person understand how to take their medication, what to do with it, and if you don't use it all, where to go with that. But when someone has an opioid, we'd like to see them be co-prescribed naloxone. And sometimes the doctor might do that, but it doesn't get delivered because it's not available in the pharmacy. So I also think pharmacists can do a lot to help people understand that opioids are addictive. And just to tell the person that, because if they didn't get that information from their doctor, pharmacists are the second line of, and people trust their pharmacists. I come from a family of pharmacists, so my grandfather had his own store, and my uncles and aunts worked there, and we used to sell newspapers in front of it when I was a little kid. It was fun, and that was the local support, right? I mean, you go and you ask questions of the person that you trust, and I think people can take more responsibility. They're highly educated to help a person not go down that path and help them stay in a healthy place.
Yeah, I mean, talk about like repositories of information that people don't tap into. I mean, I think a lot of people don't realize that pharmacists have doctoral degrees. And, so like when they ask you, do you need to know anything about this new medication? I think most of us are just like, no. And then we just kind of like rip off that huge packet, which, might have information that we need in it and just, recycle it or throw it away. But
you can't even see because it's so small these days. It's like, if you have any problems with your eyes, forget it.
I'm always so thankful though, when they're like, don't have milk with this, or
right.
It's like, well, it's done. I totally probably would not have read that. I know for me, I have some kind of hypochondriac impulses. And so I make a point of not reading as much as I can about any medications I take, because then it's like I will have a headache and my mouth will get dry and I'll arrhythmia or something, So having someone explain that to me is important.
Well, and side effects, which ones are important, which ones aren't, right? Which ones you had to the emergency room, or which one you just okay, this is going to happen, it'll get better. Understanding Tylenol and aspirin and the difference between them can hurt your liver. And if you have a bad liver to begin with because you're taking substances, that's not a good thing either. So there's lots. I think, pharmacists are giving flu shots and shingle shots. And so right now we could use them with our COVID vaccinations. So I think there is tremendous support that can be coming from that community.
Yeah. Well, that's a fantastic perspective, and I think the hard part is just saying some like, how do you mobilize people to move? I think that there's some pharmacists who really do take a lot of personal responsibility and who are thinking, how can I move into this space? How can I make a difference? But I think there's a lot of people, and this isn't, I'm not just picking on pharmacists. I think this goes for people of all professions who kind of just they just kind of go with whatever they feel is necessary, or if there's pressure put on them, they might go in that direction. But there's more reactivity than proactivity, if you will.
Well, again, pharmacists are often in retail situations, right? And they're the retail part of that job is overwhelming, and it's throughput, right? So I think there needs to be an understanding that pharmacists are huge resources. They're a resource to the community. When people are misusing medications like they are, then they should be out in front helping people not do that anymore, rather than judging somebody who walks in the door who they may think has a substance use problem. Stop judging and help educate and help them feel that there's a place they can go. Let's say somebody realizes they're dependent on the medication and they want to get off it. Well, ask your pharmacist and have them have resources to call my recovery coaches, right? Call a recovery coach and we'll come over and we'll help out, right? We're not linked to pharmacies like that.
Totally. Well, and I think also, I mean, again, I'm not trying to like just put pharmacists under a microscope, but I think that, they're there, but there's also like the techs, like there's a lot of people who also weigh into that experience, because certainly like when I think of when like working with MAT clinics and having people go to a pharmacy for Suboxone, one of our medication-assisted therapy drugs, a lot of times you'll hear these stories where people just have these really unpleasant experiences. And I kind of wonder, like, would there be an opportunity here, if they're not already doing it, for like a Walgreens or a CVS to have some sort of mandatory training around this particular issue, given that it's still escalating, given that it's something that's still going on, and given that we still hear these really unfortunate stories.
I think it's critical. No, believe me, I've heard those stories, and I've heard games being played with people with their Suboxone where they won't give it to them to the 30th day, and and if you can't get to the pharmacy that day, then you're going to be without it. And there's no recognition that this is an important life-saving medication. And when you're messing with it, you're hurting somebody. You're treating them like they don't deserve to have that medication. And they do deserve. It's no different than insulin for a diabetic. Nobody gives a diabetic a hard time about their needles and their insulin, but they do if someone has a substance use disorder. And I think you're right, ignorance, right? They're not educated in what the addiction is. We had to stop and educate physicians. In the beginning of this epidemic, the medical schools changed the way they educated their physicians because they realized that they did not have a good grounding in substance use and addiction. They did not know that the medications they're prescribing could become an addiction or dependence. So we're starting to change that around. We should be doing the same thing in pharmacy school about how do you interact with a client who is getting those drugs, or how do you educate the rest of the clients that this is fine. This is part of your recovery, and we support your recovery. We support your recovery is what people should be feeling, and educating people. I do that all the time. That's my major role. Is to I've recently been educating workforce, people who help people get jobs, about what it's like to work with a client who has a substance use disorder, why they act different than the average Joe off the street. Who is healthy. And so those are all areas that we could do a better job at.
Yeah, and it's interesting. I think sometimes people discount these like, we'll call it like softer skills or like soft touch or something like that, where people just say, well, like it would be nice if it were easier, or if you didn't have to deal with it, but it's not all that important. And I think that it's really critical, though, that we don't overlook it, because these are the sorts of things that make people keep their addiction a secret. These are the sorts of things that allow it to grow. These are the sorts of things that get people turned off from medication-assisted therapy, and honestly can eventually lead to overdose. I don't think it's too strong of a statement to say that these sorts of patterns literally kill people. It's not direct, but it's a very clear but indirect link, where when we act in these ways, there's certain people who are going to fall through the cracks, and there's a percentage of them who are going to die.
Exactly. And when a person is in active addiction, their sense of self is not good to begin with. And so they isolate, they're shamed, they're embarrassed, yet they're overcome by the need to get the drug because of the addiction. And so I think it's important that people that realize that when people in the throes of their addiction do things that are not great. They manipulate, they lie, they steal, they do things. That's not who the person is. That's the drug working on their brain and creating this compulsion, this need to have that medication or they're going to be sick. And so we need to look at the person separate from that. You need to look at the person as someone who needs help, who needs the assistance to get better, to get well. There are ways to get well, and we need to help the path get easier to go on that recovery. We don't make it easy at all, in any sense of the word, for people to get help.
Yeah. There's that judgment aspect that gets in the way. So I want to pivot for a second. We got a question from Jennifer, and it's a longer one, so I'm going to sum it up. You can kind of skip to the bottom, but she's wondering about people in transportation industries like pilots, airmen, those who are being pretty heavily hit by the pandemic because the industry obviously has just been devastated by what's happened, and wondering whether or not we're seeing an increase in those sorts of clients in taking advantage of our services. I don't know. How about you, Kathleen? Is this?
I don't know that I could answer that. I can tell you that the average person who's suffering from unemployment or reduction in employment, a lot of self-medicating is going on with alcohol and with substances. So, and that particular group of people has a history of some substance use disorders. So, I absolutely would be. I'm afraid for everybody who is under anxiety, under pressure, has anxiety, and doesn't know what to do with it. We need to teach people healthy ways to deal with that sadness, with that anxiety about what's coming tomorrow, because nobody knows. Is my job going to come back? Am I going to be recalled? Am I going to be able to pay my bills? Is my rent going to come due and I can't pay it? That's a whole lot of heavy duty things for people to work with. So. That was a nice question, and I don't know any statistics or information that's come out just in that group of people. They will when they start going back to work, and I believe that the industry is starting to pick up, at least for airlines. They're saying they're going to start calling people back this summer. So,
yeah. And it's a really good point, I think, to highlight that really addiction is a disease of maladaptive coping, right? At its core, what we're looking at is people, it grows, right? And there's neurological element, there's a lot that goes into addiction, but at the heart, generally speaking, of folks who really get to a point where you would call it an addiction, they're trying to deal with a lot of pain or a lot of situations in their life, and they don't necessarily have or feel like they have a healthier way to do it.
right.
And part of the kind of like the cascade of negative behavioral health and psychiatric outcomes that we're seeing right now because of COVID is, first we've got like this primary issue of all this stress, all this anxiety, all this depression that we're seeing, just this huge spike. And then people, well, you got to deal with it somehow, right? It's just like any other body system where you take something in and you have to let something out. Stress works the same way. You've got to find a way to process it and let it back out. And if it's not something that you're very skilled at, or if it's something where you've already been leaning on substances to do that, industries that have been particularly hard hit, yeah, I'd imagine you'd see the same thing.
Well, and I worry about women, particularly who are home. So many, I don't know the exact statistic, but the largest number of women ever have left the workforce and are home helping their kids homeschool. And the pressure of that, being at home after having a job or a career and being responsible for your children's education, which is a huge, some people might like that, some people don't, it's not there. And trying to manage the household with the reduction in income, that's huge. And I think we're going to see the backlash to that. Particularly, we all know the history of in the 1950s and women who were isolated and in the suburbs started drinking. They would have the wine and these are generalizations, but the ability to be home, stuck at home, not have a job, and not have a transportation was very hard. And so we're going to see the same thing. We're going to see people coming out of this with, well, we all know we have the 15 pounds that we all gained, right? Sitting at home. That is hard for a lot of people. That's like going to school for a year, right? Our health clubs closed. All the outlets that we had are not there the way they used to be. And we have to start being creative. And, that's hard. That's very hard for people to change behaviors.
Yeah, well, absolutely. And the newness is, it's always a switch. And this could be a good segue to get back to telehealth, because I know that this is something as well that, from a public health perspective, you've kind of had a bit of a love-hate relationship with. I know that so in terms of telehealth, kind of as I mentioned individually, it can be very effective. And something in particular that I know has been really heartening for me is that there's been legislation adopted by, I think we're at 14 states right now, and it's going to go up to about 18, that allows psychologists such as myself. This is not currently available for professional counselors or social workers, but that allows psychologists actually to practice over state lines. So I can actually practice, across 14 states. And so right now I'm actually working with people from Arizona, Georgia, Oklahoma, and Pennsylvania at the moment. And to me, in many ways, this is the future of healthcare, in my opinion, particularly of behavioral health, is that it doesn't matter if you don't live near a specialist, you could see that specialist. Particularly if it's something like psychology, where you don't have to be in the same room. But as we were talking about earlier, when it comes to groups or certain circumstances, telehealth, it can kind of get you part of the way there, but there's also some problems. So, I mean, what do you see of the future of this, either as COVID wears on, but then also after we see more people with vaccinations and things start returning back to normal?
Well, I do want to share some feedback that I've received from people who are doing some of the virtual groups. They've had an opportunity to have groups with people all over the world. And it has opened up opportunities to have groups that are more significant or more helpful to them, not just the ones that are in your community and in your area. So we've really expanded access, which is important. Now, the same thing with a physician or a psychiatrist or a social worker, being able to see your client more frequently, because you're not coming into the office and they're not driving, they're not having to find transportation, which is hard for people to get, or they have to leave work in order to have that visit. I think it's really important. But I got to tell you that one of my physicians offered me telehealth an appointment, and I went to I need the comfort of seeing you. I know telehealth's not going to do that. How can you examine my body when you're not there, right? So it's going to takes a little time, but as far as access goes, you can now get appointments with people where you couldn't get appointments before, because they are available and you're available, and you can do it at odd hours too. So I think telehealth is absolutely significant for communities that have shortages. So when you say that you can treat across state lines, Will County has shortages of many of these behavioral health positions. That's why we're trying to fill the recovery coach, but we don't have psychiatrists, and we don't have we don't have treatment. We don't have a lot of treatment for people without good insurance. And so you will get people who will contribute online and that will be fantastic. Absolutely.
It's a game changer in that respect, in terms of there's all sorts of inefficiencies where people have open spots, and I'm sure someone would love to get in and see them, but you can do it. But now we're finally starting to see this get nationalized.
Right.
It's a really cool paradigm. In the past, it's been inhibited a bit by jurisdictional issues, or egos sometimes, in my opinion, of ethics boards, or even sometimes financial things, with the idea of being say, for example, there's a small community in Oklahoma, and they're well, we don't want the Chicago-based psychologist coming in and taking our business, right? There's only you could start to see some of those tensions as well. But insurances don't cross state lines either. So you're out of network. What happens when you're out of network? And how are you on network when you're in front of my screen? You're right here with me, right? I mean, what is out of network now? It sort of changes that dynamic. Yeah, absolutely. Well, all right, so let's pivot again. And this is I want to ask your opinion, because I think this is fascinating. So I posted a poll and an article recently about New Jersey's decision to have people who smoke cigarettes jump the COVID vaccine line and basically go to the front of the line right along with people who have like congestive heart diseases, who have these chronic conditions that put them at great risk. And their rationale for that was that because you are smoking, you are at greater risk of serious complications and death, which would actually then clog the ICU. And they don't want to do that. So they took smokers, cigarette smokers, and put them to the front of the list. The poll that I put in on LinkedIn about this, the way they weighed in was 85% said no, this was a bad idea, they shouldn't go to the front. 15% said yes. So I'm wondering, from someone in public health, from your perspective, where do you land on this and why?
This is a hard one because just the classification of who gets the vaccine first has been filled with problems, and never in health do you ever want to categorize someone sicker than the other person, right? You don't want to say you're more important than this person. We want to give care to everybody, and we want to do it quickly, and you just can't do that. And I can tell you, if you start identifying illnesses or predispositions to an illness, it's a slippery slope, because people who use substances ruin their livers, ruin their hearts, have sepsis. I mean, there's all sorts of things that would hurt if you would complicate COVID. So where do you draw the line? And where do you draw the line with people who actually have lung cancer but weren't smokers, right? So there's an increase in that. I'm not in favor of that. I'm more and I think it could be handled in a doctor's office. If your doctor decides that you need the vaccine, I think physicians should be able to make that happen, and not just categorize and put it in the public health department's responsibility. I know seniors right now are really struggling with trying to get their vaccines. And first it's an access point, then it's a how do I get there, and why am I not able to get there and somebody else is? And every state has a different categorization. So this is very confusing to people, very, very confusing.
I agree, and it's tough to verify too, right? It's like, like maybe I should go buy a pack of Marlboros or something.
Put it in your pocket, so you're like,
I'm clearly a smoker. Give me my shot. But even that aside, what it brought up for me, and I would tend to agree. So I'll say, like full disclosure, like I would agree with the folks who are saying probably not the best way to go here. Although I do understand the arguments for doing it. But what it presses on for me is this idea of like what you're saying. Where do we draw the line between like a choice in a disease or a choice in a medical problem? And in cigarettes and nicotine in particular has always been kind of an odd one, right? Because it's something that, aside from cancer and death, it doesn't really destroy your life in the same sort of way that some of these other drugs do, where it impairs you. It can lead you down a really difficult place. And then we also have all of these medications that are available, FDA approved ways, like psychological treatment. I mean, a lot of ways to quit smoking if that's what you want to do. So this idea of, is addiction a choice, I think is something, or do you have a choice, I think is a much stickier wicket when we're talking about nicotine. But I think that it does bring up this question of sort of saying, okay, so anyone who's got a compromised immune system, anyone who's hurt their lungs in some way might be more disposed to this. Would we say, for example, that someone who say has an opioid use disorder, would we say, you kind of get what I'm getting at here? Like, where do we draw the line on that?
We make judgments, and anytime you're making a value judgment about who's more important than the other because of their illness, it's not good. It's like organ transplants. When they prioritize organs to go to the sickest people, and when you're a loved one who's a person who needs an organ, you don't care that someone might be sicker. You want your loved one to be taken care of. So, and who determines if that person is sicker? You have to have evidence, right? You have to have scientific evidence in this kind of epidemic. That's not going to roll out. I mean, we're having a hard enough time just getting people to identify that they need the vaccine. We want them to take the vaccine. I'd spend more of my time helping people who think the vaccine isn't safe, educating those folks to get it, than trying to identify the people who should get it first. I think we need to get it out there as quickly as possible and vaccinate as many people as possible, period.
Yeah, well, and you make a really good point that it's really tough business trying to say, like, who deserves the vaccine first, right? Like, there's no real answer to that question. It's almost like a moral thing. Although I do think it's interesting as well that this is almost like a reverse policy. You mentioned organ transplants. I mean, I've done pre-surgical evals back in my time when I was in the VA, and it's actually the other way around, right? Where, like, if you have an active addiction, you might not get an organ because the idea is you're not going to treat it very well, or that you might relapse. But here it's like, if you are smoking, then you're more likely to get your vaccine.
Yes, and what makes sense for that? I'd rather you spend some money giving me ways to quit, right? So you can get your lungs back in shape. And the other thing is, so someone made a determination that smokers were clogging up the ICU beds. Is that valid? I mean, is that the folks you're seeing in your ICU beds? And I would think that would be different all around the country, who's clogging up the ICU beds. Let's say you have a very elderly population. Well, those folks are probably going to end up in your ICU beds faster than the rest of the community. So do you do essential workers, people who are exposed all the time? I mean, it's hard. This is not an easy, and I don't think necessarily disease way to do it. Yeah, I don't think people will go along with that. I can tell you there will be a backlash to all those smokers. I'd be afraid. I would be afraid that wouldn't sit well with the community.
That's true. Then maybe you're like getting even different sorts of like sideways glances about smoking. They're like,
there's already a social stigma with smoking. That, in fact, that's how a lot of people quit, is because when it became not cool to smoke, couldn't smoke inside or outside, people quit. And that's a good way to do it, right? That's a good way to do it. But to put someone, reprioritize them because they are smokers, doesn't make sense to me.
Yeah. Well, so we are down to about 10 minutes left in the show today. So I just want to remind any new viewers or who didn't come in the beginning, who haven't seen the show before, please feel free to write in if you have any more questions for Dr. Burke. Because, I'd love to have her back on the show sometime, but it also might be a little wild. So this is where we end. The last question that I prepared that I wanted to talk about today has to do with, in particular, the public health system and how it relates to addiction. Because when someone has an addiction, generally speaking, and when they're getting into the end stages, they lose their job. Because they can no longer function adequately in that job. And part of the issue with that is that they would lose their commercial insurance, which is how where most of the addiction beds are, substance use disorder programs. It's really hard to get treatment, and at least here in Illinois, the reimbursement rate on Medicaid is so low that a lot of providers don't choose to service it, and so then you might not even be able to see as high of a quality of provider. It's like everything gets very constricted, and it's tough, right? Because that's like saying, okay, so like say you're at like stage 3 or stage 4 cancer, well, that's it for you, and now you can't even get any help, right? You should have caught it when it was earlier. It kind of seems backwards, and so I guess my question for you is, how do we start, and this is a very loaded, large question, but how do we start to change this dynamic where we are very reactive to addictions, I'd say, as a society, where we're all about treatment, but we don't invest as much in prevention, and on the treatment side, we don't invest nearly as much as we need to on the public aid side of treatment, which is honestly where a lot of people make it to when this advances to a certain point.
Actually, that's what a lot of my job is identifying areas in Will County that are barriers for people getting care. And most of the barriers are because they do not have insurance or it's Medicaid. And that leaves them with one or two choices, and those choices end up being filled. And so here's my take on that. I feel very strongly that we have a system of care that is dependent on the person with the illness to resolve their issues. So if, let's say I have a sore throat and I go to my primary care physician, right? and I ask them to look at my throat and determine what's wrong. And let's say that he or she decides, oh my, you need to get those tonsils out. I mean, really, it's not good. You know, you're older, you need those tonsils out. It's causing other problems. Here's the referral to a general surgeon. You need to go to a general surgeon, get an assessment, and then go from there. So I go to the general surgeon, that office, my primary doc makes that referral, probably calls and says, here's what's going on. I go to the general surgeon says, oh yeah, we're going to take him out. When are you available? And they determine a time when I'm going to be available. Their office calls the surgical, the hospital and the surgery department and books that. And then the hospital calls me and tells me when I have to show up and when I'm going to be there for surgery. Now let's take someone with a substance use problem. If you have a substance use problem, there is no referral standpoint. You can go to your primary care physician, and actually that's getting better. We're trying to get people with homes, medical homes. But let's say you don't have a medical home. In fact, if you're in the midst of your, deeply in the midst, you probably haven't seen a doctor in a very long time because you have no insurance and you can't get into one. So what do? Who do you call? Well, they tell you, call the treatment centers, and everyone says, I need to be detoxed, or everyone has a different idea of what they need. And so they try and get admitted. They call a treatment facility and say, I really need help. And the facility says, do you have insurance? And they say, no, boom, that's it. Okay. Well, we don't take Medicaid patients. Okay. So you call the facility that takes Medicaid. I'm sorry, we don't have any beds right now. Call back tomorrow. Call back every day for the next 2 weeks. All right. That is a ridiculous system for someone who's altered and ill. Well, their brain is being affected by the drug, and they're being asked to be accountable and responsible for finding their own care in a system that doesn't make any sense, that's not linked to healthcare in general. And it's like the emergency rooms. When someone overdoses, they discharge that patient. A patient who overdoses should never be discharged into the community. I believe we need to have a closer connection to the healthcare system and manage treatment in the same way we manage regular healthcare. The separation, the lack of referral system, the lack of understanding what the disease is influences how an insurance company will reimburse. They make decisions that are not appropriate based on the recommendations of the therapist, but they feel they know better. You don't do that in healthcare. Even when we had managed care, you could still get the care for a patient that you knew they needed if you were a physician advocating for that. So I'm sorry, it's long-winded. It's a real hot spot for me because I don't think people who are ill should be the person who has to direct their care and find care when it's a system that nobody knows about. I mean, when a family member gets sick, where do you go? Even people who are well-educated in healthcare don't know where to go.
It's so tough. And even then, how do you know that you're going to a good place?
Right.
Right. So I had an experience actually. When I first came to Chicago, I was the director of the addiction service line at Linden Oaks and Edward Elmhurst Health. And I was maybe like about a month or two in, and I got a page from the Edward emergency department saying, we've got a patient here who says that he just got released from Alexian Brothers or something like that. And from detox from heroin. He only has like a little bit of buprenorphine left, and he's scared to leave the emergency room because he feels like if he leaves, he's going to relapse again, and we don't know what to do. And so I came over, and I met with the guy, and he'd been like up for 48 hours straight. He was just desperately trying, like he just did not want to go out in the community, felt like he had no options. And so, like I said, all right, I will help you. And so I took his insurance card, and he had Medicaid, and here I was. I had a new baby at the time, but let's just say I was a lot more cogent than he was at that moment, even with the lack of sleep. Trying to find some place for him to go, and even with the connections that I had in the community, even with the fact that I had slept to a degree, I literally wasn't able to do it, and it was so frustrating. Like I called the number, and I was getting bounced around, and it was like 4:30 at the time. And so a lot of places were closed, and the people that I knew, like they weren't at their office phone anymore. And it was incredible. And the best I could do with my connections and everything that I could do was I got his mother, who'd previously kicked him out of the house, to hold him for a night so that he could get to a methadone clinic the next day. And that he was thankful for, but that was it. But it was so humbling. It was so humbling because it really shone a light on how difficult it is, particularly if you have Medicaid, to find a place to go.
And the other part of that is a lot of people don't have places to live. So when they're asking for help and they're wanting to get admitted, it's a 9-to-5er, and that needs a change. There should be at least an emergency situation, just like there is for healthcare. Because let's say someone overdoses and they're in the emergency room, it's not necessarily between 9 to 5, and then it takes so long to get someone admitted because they have to do an assessment prior to the admission, or the insurance companies won't accept it. Now, when someone shows up at the emergency room with heart pains, they're not going to say, wait a minute, let's see if your insurance company will pay for this first before they admit them and do some tests. It's backwards. It's not appropriate. And it's because of this stigma that somehow you made yourself sick, therefore we don't have to worry about it. When in reality, your brain is the illness. The brain is the diseased organ. Let's treat that diseased organ. Let's stop punishing the patients. It's the same with mental health. If you have a mental health disorder and you go into the emergency room, they don't know what to do with you. They don't know who to call. They don't know where a patient can go because there aren't very many places that accept mental health patients. So it's awful. I mean, it really is awful. And I think we should shame on the United States for having a system like this.
And to be honest, you even brought up another interesting point. So I'm actually going to be doing a ethics webinar later this afternoon on ethics and addiction treatment. But another really interesting topic around this, when we talk about differences between addiction and then other medical conditions, is this question of decisional capacity, where, are people, when it comes to their substance or a lot of things that are around this reward system, do they have decisional capacity? Do they not? How do we treat that? There are states, Illinois is not one of them, where you actually can you can mandate someone into treatment. You can do involuntary holds because people are viewed as a risk to themselves because of their addiction. And I think that's just a really interesting question about where we draw that line.
Well, and I know I'm not. People feel very strongly about their own personal decision making, and I had a situation where I had to admit someone with a friend of mine with a mental health problem without his, agreement, and that I lost that friend, but he wasn't safe. I mean, it wasn't safe for him to be where he was, and yet I think he believed he was fine, and where he went, he believed he was fine, but I could not get an emergency room physician to make that decision. Someone else had to make that decision, and no, come on. I mean, you need to understand, just like the police are often the people who get called when someone needs help, and they're less prepared to be able to make that decision and where somebody should go. So a lot of times the shelters get people, and when the shelters get people, then that's a whole different situation. So it's very complicated, but I think we should start talking to the healthcare system about how we link, and the insurance. The insurance people need to get to the table and make this better. Now, I know in Illinois that our public aid department has heard us. They've heard that you can't keep doing this. Is not working for people who are overdosing, right? It took people overdosing for them to pay attention to the system doesn't work. The system of care that we've provided, the amount of money we pay, it just doesn't work. And but again, knowing it doesn't work and fixing it are two different things. So I'm adamant that we need to link the two systems and treat it more like we do a heart disease, or but then we need psychiatrists, and then we need nurse practitioners, and then we need providers of care, psychologists who can do that. And right now there's a huge shortage.
Yeah, well, so it sounds like we will see your name on the ballot running for office soon.
No. I'm not a politician. what I am is a grassroots. Okay, I will work with the community, and I will communicate loudly what I believe needs to be done. But I want to do the work. I want to get people care. I need to be at the level where I see the results, and that's what makes me happy. That's why I've got people on the street trying to get people naloxone, because that's what counts.
Well, and you absolutely walk your talk, because truly, I mean, I don't remember when I first met you, Kathleen, but I'm sure it was out while you were doing an event, because you were constantly out hitting the pavement trying to make this better. So that being said, we are at the top of the hour. So if you could just are there any final thoughts that you'd like to leave our audience with today, just to sum up our conversation? Anything else you'd like to say before we call it a day?
Innovation and new things, we need that. So all of you people who have those kind of ideas, I think we need to put that into the system of care. And anyone who needs help in Will County, who needs naloxone, please contact me. I will get them. They're free. It's free. The services I provide are free. And I do virtual training, so I'm there for you if you need it. But just remember that the next person who has a substance use disorder could be your son or daughter or parent. We're all humans. We all deserve the best care.
Yeah, and I can vouch. It is free, and Dr. Burke, naloxone flies off of her. You know.
Yes, no, I have a whole office full just of naloxone. So
I actually got my dose that I carried around for a long time from you when I was at one of your trainings, and then actually I ended up giving it to someone who needed it, not administering it, but someone who really was scared. I can't remember what the situation was, but I ended up giving it away. So it absolutely, you know, it flows.
And that's what I tell people. If you don't have to take it because you have the problem, you may know someone who has the problem that you want to give it to so they're safe. You can't get better if you're not alive. And with fentanyl out there, we need to keep people safe until we can get the care they require or want.
Absolutely. Well, so with that, we're going to close up shop for today. Thank you, everyone, for listening. If you'd like to tune in again next time, I think we have another show coming in about a week or two. Please subscribe to me on YouTube. You'll get a notification. Follow me on LinkedIn, Facebook. Dr. Burke also is on LinkedIn. You can connect with her there. Do you have any other social media that we should be promoting, Kathleen?
No, I'm on Facebook and LinkedIn. And my phone number is 708-205-5782. That's the connection. If you need naloxone, I can make that happen. So please reach out if you need that. Now, I want to counter that by, I'm not a physician, so I can't, I'm not going to be answering medical issues. I'm not comfortable with that. But if you need help with the naloxone or getting into care, I can help you with that.
Kathleen is so devoted. She just gave out her phone number on the internet. I don't know. Maybe one day I will be so brave.
I thought about that, but I'm like, if people are listening, they're interested in the treatment area and what we do. So I'm all over. I'm there.
All right. Well, thank you again, Dr. Burke. Thank you, everyone, for tuning in. We'll look forward to having another conversation again soon.
Thank you, Aaron. Thank you for having me. Appreciate that.